We're going to be covering your lecture on pharmacodynamics of radiopaque contrast media. And this is chapter 7, I believe, in your book. I have it right here. And it is actually an interesting chapter. It goes pretty deep into, different chemoreceptors and all of that good stuff, and we're not going to go deep into that. I want you guys to know the basics so that you are able to understand the whys of a reaction. So you have key terms that you're going to need to know. So when we talk about iodinated radiopaque contrast media, the pharmacodynamic effect can be therapeutic, diagnostic, or adverse. So those are the different ways it can go. So the adverse effects elicited by contrast depends partially on the serum or tissue iodine concentration and osmolality, and their calcium chelating, anticoagulant, and immune system saturation abilities. So there's factors, a lot of factors that go into this. All right, so when we talk about our diagnostic pharmacodynamics, so we look at the serum iodine concentration. Now the range needs to be between 280 and 370 mLs to see the contrast within the lumen. So the injection must be equal or greater than the blood flow. So if the injection is too slow, the contrast will be diluted, and high concentrations prevent the penetration of photons. So when we're injecting a concentration that is higher, it's going to absorb the photons. So you will have that contrast differentiation between the tissues. So you can see the vessels well. So CT can have digital subtraction to help see the anatomy of interest also. So we can subtract out the normal tissue that's not enhanced with the contrast. So, categories of adverse reactions to contrast, where there's minor, intermediate, and major. Vasovagal response, it's a reaction to the procedure rather than to the contrast media itself. So, reactions to contrast agents. So, clinical manifestations of vasovagal include pallor, cold sweats, and syncope. So, symptoms of vasovagal reactions, so there's tachycardia or bradycardia, and hypotension. So if the heart's beating really fast but it's not really pumping blood because of the vessels have dilated, so the blood pressure drops out, so the heart beats faster trying to compensate for that, so you have tachycardia with hypotension. So it's really important that you take a blood pressure and you do a pulse count. So no adverse effects of contrast are generally mild, but they can go to life-threatening. So it's really important that you're able to watch your patients and do what's best for your patient. So you will not understand how scary it is until it happens to you. Like I said, I've had a patient code from the contrast media, and it is horrifying. So you have to react quick and do everything you can to save the life. So, clinical manifestations of iodinated contrast media. So, the feeling of flushing or warmth may result from a bolus injection of high osmolality contrast being injected rapidly. So, if we inject it really fast, it's going to get really hot really fast. Normal. Nausea and or vomiting. So, feelings may pass quickly or may be a precursor to anaphylactic reaction. So nausea and vomiting don't necessarily concern me too much. It can be from the rapid fluid exchange that makes their stomach uneasy. If you open up an alcohol wipe and wave it over their nose, it's going to cause them to vomit or be fine. So I'm willing to take that risk 90% of the time. I always open up an alcohol wipe and they either throw up or they're fine. So most of the time they're fine, which is great. A headache, it may pass without note or may be a precursor to anaphylactic reaction. A lot of patients get headaches, but if they get like a really bad headache with the onset of the contrast, it's irritating to the vessels, so it can cause headache. And it's because of dehydration too that can give them a headache. So there's multiple reasons they can get a headache, but a sudden onset of headache as soon as you start to inject can be a concern, so you need to pay attention. So pain at the injection site. So burning sensation that occurs with the result of leakage into the surrounding tissues, or simply may be the result of a large gauge needle and that's supposed to be contrast, sorry, contrage unit. So a lot of the times when we start to inject, the contrast is really irritating to the vessel. So they'll have some burning just within the first like 5 seconds, and then it subsides. If it really burns, I mean, they'll let you know this, ow, and you can feel it, and you can feel it extravaganting. So you need to stop your contrast injection immediately. So an altered taste may be metallic, so that's normal. It results from the iodine content in the contrast material. It causes a metallic taste, kind of like they're sucking on a penny. So I always say that to my patients. I said, you're going to get a feeling of warmth throughout your body. You may feel nauseous. You may have a little pain for about 5 seconds at the injection site, and it may, be like you're sucking on a penny. All of that is normal. Anything above and beyond that, you're going to want to let me know, and I'll let you know if it's normal or not. Okay, so what you need to do, you need to notify the radiologist or the radiology nurse. You need to stop or slow the injection of contrast. So I think it's funny that they say notify the radiologist or the nurse first. First thing I do is I stop or slow the rate of contrast. I observe the patient closely and reassure the patient that they're going to be okay. Now, if they're having a major reaction, you're going to want to call a code. It's better to be safe than sorry. You do not want a patient where you're like, oh, do I call a code? Do I not call a code? When the patient codes. So you've wasted critical time. Really important that the patient gets early intervention. A lot of the times the code team does not mind coming and responding to something, even if it's not a code. They want to do what's best for the patient. So make sure that you get on the phone with your radiologist if the patient's, saying, I'm kind of concerned, my throat feels a little tight. So call the radiologist or radiology nurse, get them involved immediately, because we'll start dropping fluids, we'll start giving them, Benadryl, whatever we need to counteract any kind of reaction that they could be having. Really, really important. All right, so adverse reactions. We have, it's estimated that every 20,000 to 40,000 patients receiving contrast die as a result. So it sounds like a lot, but in reality, we're doing, 40 cases a day, and look how many facilities there are. So the numbers come fast. So although the odds of death appear to become very or rare, it's very real when it's you and your patient. If you're in outpatient imaging, calling 911 and waiting for them to come, you just hope and pray that they're close. So pharmacodynamic effects, so there's osmolality effects, chelation effects, anticoagulant effects, immune system-like effects, and renal dysfunction and thyroid storm, what they call thyroid storm. So osmolality effects, it's where the contrast contains a higher osmolar weight than the blood. So it causes transient rise in intravascular osmotic pressure, fluid from the surrounding tissues is drawn into the vascular lumen to elute the active particles. Fluid from the red blood cells shrink and become less pliable, so that's not good. Extravascular fluid decreases, causing vasodilation and flushing. So after a short injection, or shortly after the injection, the cardiovascular system circulates and dilutes the hyperosmolar contrast. So extra particles inside the vessel are moved away in the current of the blood and shifts from the intravascular to the extravascular space. So it provides equilibrium. So now when you're injecting that, the patient's heart will beat faster. That is normal to compensate the extra fluid with the exchange and us providing another 100 cc's or however many cc's of contrast we're injecting into the patient. A lot of times we'll follow it up with saline also as a saline flush chaser. Okay, so some of the effects, so the adverse renal effects, so initial increase in renal vessel fluid volume caused by hyperosmolality molar fluid shifts caused by a prolonged decrease in renal blood flow leads to tissue ischemia, and urine becomes hyperosmolar and will cause osmotic diuresis, results in dehydration of the patient. So it's really, really important that you understand that there are renal effects, and with the exchange of the tissues and the dehydration of the red blood cells, that it leads to ischemia, that the red blood cells are affected. That's why we want to know their history, and it will dehydrate the patient on the inside. So we need to make sure that the patients drink lots of fluid after a contrast injection. We dehydrated them from the inside. All right, so overview, recall. Intravascular contrast has higher osmolar weight than the normal blood stream. So intravascular administration of contrast will cause a transient rise in intravascular osmotic pressure. Fluid from the surrounding tissues is drawn into the vascular lumen to dilute the osmotically active particles. This happens because there must be equal pressure between the intravascular and the extravascular spaces, trying to get homeostasis. So looking here, as contrast is injected, osmolality increases, blood entering the capillary bed is hypertonic to the fluid of the surrounding tissues, and extravascular fluid crosses the semi-permeable membrane of the capillary to reach isotonicity, causing hypervolemia. So fluid is drawn from the red blood cells, causing sickling. I'm not sure exactly what that means, but it causes them to become dehydrated. So flexibility of the vessel wall allows vasodilation to accommodate hypervolemia. All right, so vasovagal reaction. What happens here with vasovagal reaction? So the vagus nerve fires and causes a decrease in heart rate. So we get bradycardia, which ultimately leads to decreased blood pressure, and the patient can faint. So if they start to get real lightheaded, their blood pressure's down, okay? So a lot of times what we'll do is we'll drop a bag of saline, and we'll put in the saline as fast as we can, increasing the volume of fluid so that we can raise their heart rate so that it's not really low. We can get it up to normal levels, and then they usually respond and do well after that. So as the blood pressure, increasing blood pressure stimulates firing of the bororeceptors and the chemoreceptors. So it's a whole cycle. There's acute heart failure that can happen also, so the intravascular osmotic fluid shifts can also result in acute heart failure in patients who already have chronic CHF. So signs and symptoms of acute on chronic heart failure, include respiratory difficulty, hypertension or hypotension, cardiac dysrhythmias, cardiorespiratory distress, and death. Yikes. All right, hormones causing fluid retention and vasoconstriction. So this cycle of trying to increase blood pressure becomes detrimental because the heart is already burdened. So vasoconstriction increases the force of the heart. So the heart has to pump against, and thus causing the heart to work harder and fail quicker. So fluid retention presents an increased volume to the heart for circulation, thus increasing the fluid load, which burns the failing heart. In such patients, it's therapeutic to use diuretics such as furosemide to excrete fluid from the body, and cardiac stimulators such as dopamine to increase the strength of the heart. So anything we do can actually increase the heart failure on patients, so we have to be careful on how we're going to treat the patient. Okay, chelation effects. So contrast can chelate or bind to calcium ions in the cardiovascular system after injection. So calcium chelation may be one mechanism by which adverse heart rhythms, such as pulseless electrical activity, so PEA, also called cardiac arrest and sudden death, can occur in a minority of patients receiving intravascular contrast. So I haven't seen this, thank goodness. That'd be horrible. So on a EKG, it shows that there's the normal cardiac rhythm, but yet the heart is not beating. So, oh my goodness gracious. All right. So pulseless electrical activity, so PEA, it's a heart rhythm disturbance of electrical impulses without cardiac contraction. So cardiac arrest, the heart ceases to pump blood effectively enough to maintain life, and sudden death, the result of a heart rhythm, so ventricular tachycardia and or fibrillation, that cannot sustain life. So tachycardia is where it's beating so fast that it's not able to replenish the blood With oxygenated blood, it's just pumping so fast. In fibrillation, the heart just shakes. It doesn't actually beat, it just shakes. All right, so anticoagulation effects. So high osmolality contrast can cause anticoagulation, so blood thinning, to occur. This can be serologically resulted in bleeding and bruising. So that's where we talked about in class a little bit about the high osmolality versus the low. So with high, it can cause blood thinning. So with low osmolality contrast, it does not appear to produce anticoagulant effects. So that's important. So we always want to use a low osmolality contrast. All right, immune system like effects. So the immune system is complex and consists of various components, including physical barriers such as skin, gastric acid, duodenal alkali, respiratory cilia, and biochemical defenses such as inflammation and proteins, immunoglobulins. The biochemical defense play a role in the anaphylactoid reaction. So this is an immediate, life-threatening reaction that mimics an anaphylactic reaction which can occur with contrast. So anaphylactic reaction, so first time it sees the allergen, it says, okay, I get it, I see what it is. And then you have it the second time and it completely destroys the cells. So the first time you're exposed to something you're allergic to, you may not have a reaction. But the second time, or you may have a real mild reaction where you'll get contrast and you'll get hives on your chest. It's like, okay, well, that's interesting. But the next time you have it, your body's going to attack it and attack it aggressively, and you can have a full anaphylactic reaction. So for me, I'm allergic to iodine, I'm allergic to latex. First few times I've been exposed to them, I was fine. And then as I'm more and more exposed, the more aggressively my body is attacking it. So each time my reactions are way more severe than they were prior. All right, so you can see here just another image of contrast. So the first time you get it, nothing, not too bad. You get a mast cell reaction, and then here, degranulation, so destruction. All right, so what happens is here when the cell bursts, you have histamine and others that are exposed to your blood, which causes vasodilation, which decreases your blood pressure. And you can go into shock with increased heart rate. And in the lungs, you can get swelling, you can get edema, and bronchial constriction. So with the release here of the SRSAs and the histamines, along with other things, and going and releasing all of that into the blood system, it's circulating, just dropping your blood pressure, increasing your heart rate, puts you in shock, your lungs start to fill up with fluid, and the airways start to close. So all of that is very serious and very scary for a technologist. So renal dysfunction. Contrasts are responsible for 10% of all acute renal failures events and are the third most common cause of hospital-acquired acute renal failure. Oh my goodness gracious, not terrible. So patients with contrast-induced acute renal failure generally present with mild, irreversible urine output. So urine output should be greater than 400 mLs per day in the event of short duration. So the serum creatinine concentrations begin to rise in the first 24 hours after the administration of IV contrast, and peaks in 2 to 4 days and normalizes 7 to 10 days. So when we give contrast to a patient that is compromised, we can put them in failure. So it's very, very important that we check eGFRs on every patient to make sure that they are safe, because one day they may be fine, the next day they could be in failure, and you need to know whether your patient's in failure or not. All right, oliguria. So oliguria with acute renal failure does not occur in some patients, or does occur in some patients. It's defined as urine output that does not exceed 400 ml a day. So you need to, they check the INOs, what we call INOs, so the output of the patient on the urine. So the urine failure may not be reversible, the renal failure may not be reversible, and the serum creatinine does not normalize. So that patient is injured for life. So diabetics. So it's now considered high risk only if there is contaminant renal dysfunction exists. So diabetic patients with serum creatinine levels greater than 4.5 mgs over DL have been reported to experience 100% incident of acute renal failure after contrast administration. So dehydration before contrast injection is not a major risk factor, providing the patient is hydrated after the exam. So if the patient, and that's your BUN. So I always look at the BUN. Is the patient dehydrated? So it will not stop me from doing an exam as long as the patient gets hydrated afterwards, okay? So you do have to make sure the patient gets hydrated or else they can go into failure. So dehydration alone can result in significant ARF if not treated. So make sure that patient gets lots of fluids after the exam. But you have to be careful because if they're compromised, their body can't filter out all of that fluid. So you have to be careful about how much fluid you can give. So that's up to the nurse and the doctors to figure out. Drugs aid in the prevention of renal dysfunction after administration of contrast. So we usually give normal saline to help hydrate patients and the different drugs here. So half normal saline, so prophylactics against contrast-induced renal dysfunction. So hydration is the most important preventative measure, provided the patient's cardiac condition can withstand it. So if you give too much fluid, it can back up into the lungs because the heart can't pump it. So it's best to begin with hydrating the patient with either normal saline, 0.45, infusion at 1 to 1.5 mg per kilogram per hour, 12 hours before the test, and continue hydration for at least 24 hours. So it's a steady hydration instead of blasting them with fluids after they have the contrast, especially if they have any kidney or cardiac dysfunction problems. Okay, FENOLDOPAM, I don't know, relatively new for treating hypertensive emergencies. See, I don't even know what it is. It has potentially vasodilatory effects through stimulation of dopamine receptor, and so increases and preserves renal blood flow through D1 receptors and stimulation. So FENOLDOPAM is included because of its frequent use currently in some parts of the United States. So I haven't seen this yet, but I'm definitely interested. I like what it does. Okay, so if we look here, so acetylcysteine is an antioxidant used to prevent renal dysfunction caused by oxygen radicals released from the contrast. It is an oxygen radical scavenger that eliminates oxygen radicals. It also works as a vasodilator in the renal tissue. Because of its relative safety, it is being used as an adjunct agent in hopes that it will prevent renal insults. So we're using it. So Mucomist, I'm used to hearing the brand name Mucomist. So with Mucomist, we'll give it to patients that have compromised kidney function to help preserve their kidney function. So it's available as a 10 or 20% respiratory nebulizer solution and as an IV form. So we usually have the patients get it from the doctor prior to our contrast injection. So yeah, it's good. So sodium bicarbonate, it's an acidic environment produced in the renal tubular urine. Renal tubular urine produces a medium for the production of toxic free ionic radicals. This is supported by the fact that these radicals are not produced in the less acidic bloodstream. So this leads investigators to study the effects of sodium bicarbonate IV solution as a prophylactic strategy against the development of renal failure secondary to contrast. Now I haven't seen this used, but I'm intrigued. I like the idea of it. So thyroid storm. So this is also called the thyroid crisis. It's rare, but potentially fatal adverse effects that has occurred after administration of iodine contrast. So it happens when the thyroid gland suddenly releases large amounts of thyroid hormone in a short period of time. Generally occurs in patients who have decompensated thyroid toxosis. The body is unable to tolerate thyroid hormones. Iodine from the contrast can cause the thyroid to produce thyroid hormone that exceeds the body's tolerance levels. So I have seen this before. This has happened to several of my patients that are in-house. So fever, tachycardia, diaphoresis, agitation, nervousness, and emotional instability. Untreated thyroid storm can lead to CHF, refractory pulmonary edema, cardiovascular collapse, coma, death within 24 hours. So I am very fortunate to have the patients as inpatients, and the nurse was able to catch this quickly. So they're able to treat the patient. How they treated the patient, I don't know, but they were able to treat the patient and they were fine. All right, so screening. Consider all the serious adverse effects that can occur by injection of intravascular contrast. The imaging technologist should use a screening method that includes the assessment of patient's medical history and current renal function status. So there are a number of questions that you should be asking the patient, and I put some of them in here. So history of allergies to medication, history of intolerance to iodine, history of adverse reactions to contrast, history of asthma or difficulty breathing. A lot of times we'll tell the patients to bring their inhaler with them if they have asthma. History of cardiac disease. Now we need to know that because if the cardiac output is really poor, it's going to change our timing, number one, on our scans, and number two, we need to know if we're going to be increasing that load on the patient, if their heart can handle it. We need to know if they have a history of renal disease. Now we're going to be running that eGFR on these patients and looking at their hydration with their BUN to see if they're even a candidate for contrast. We want to know their current medications. Are they on metformin? Is that something that we need to have them stop for 2 to 4 days, depending on what the doctor's orders are or what the clinical site says? History of diabetes. Sometimes they don't know their medication, but we'll be able to say, do you have a history of being diabetic? And they'll say, yeah, I'm diabetic. I'm taking medication. Okay, well, what medication? Oh, metformin. So you get to it roundabout. Plus, being diabetic has additional stress on your kidneys, so we need to know that. History of sickle cell anemia. So it's usually found in black patients, but I wouldn't just isolate it to black patients. So the reason that we care about sickle cell anemia is because we dehydrate the red blood cell. So we need to know, are we going to put them in a crisis if we dehydrate a bunch of their red blood cells? They have a history of multiple myeloma. Is the patient pregnant? And any current CNS trauma? So all of those are very, very important questions to ask, and we need to know before we give contrast. So drug-drug interactions. So patients requiring intravascular contrast administration have an indwelling IV catheter where medications are infused. Occasionally an IV drug may be required to improve visualization or counteract severe adverse effects from contrast. So example, vasodilators improve delivery of contrast to small arteries that may be inaccessible. So vasoconstrictors decrease delivery of contrast to visualized beds that are not normal and are supplying a tumor. So vascular beds within a tumor may not respond to vasoconstrictors as normal vessels do because they lack elasticity and the receptor density. Therefore, contrast will be significantly delivered to the tumor vessel when vasoconstrictors are used. So really important. One thing that we need to do is flush any kind of drug that would be in an IV catheter before and after our contrast. So vasoconstrictors and vasodilators, adjunct medications, are generally injected immediately before contrast. Drug-drug interactions in the form of chemical incompatibilities may occur between contrast and these adjunct drugs. So chemical incompatibilities that produce insoluble precipitates can occlude IV catheters and possibly induce an embolism within the patient. So we need to be careful. Number one, we don't want to blow the IV. Number two, we don't want to cause a reaction within the patient. It's important for the technologist to understand which drug contrast combinations are known to cause this phenomenon and how to circumvent the problem. So talk to the nurse and make sure they flush the IV and stop any drugs that would interact with the contrast. So if we look at barium sulfate, enteral barium sulfate can cause both GI and respiratory adverse effects. So in the GI tract, barium sulfate produces an insoluble participate with calcium to form barium fecaliths, which can lead to constipation, intestinal obstruction, ulceration, perforation as a result of the impacted colon. So surgery intervention may be required to remove them. So they turn into rocks within the colon. So your large bowel its job is to take the water out of your food and recycle it within the body. So it's going to take the water out of the barium. So it can cause the barium to turn into like bricks within the colon, and which can cause ulceration, obstruction, and it can eventually perforate the colon. So it's really, really important that the patient stay hydrated so that the colon doesn't take all the water out of the barium. Distension, cramping, and diarrhea may occur. Rarely, chemically induced appendicitis has occurred in patients who retain barium in the appendix. So the appendix doesn't like it, and you can get appendicitis from that. If intestinal perforation occurs, large amounts of barium can cause intestinal infarct, severe peritonitis, and even death. If it gets into the lungs, aspiration of the barium sulfate into the lung generally does not cause harm, provided the amount aspirated is small. So you don't want large aspirations. So large aspirations may lead to pneumonitis and nodular granulomas of both lung tissue and lymph nodes. So asphyxiation and death have been reported in at least one case of aspiration. So normally they'll just sit at the bottom of the lungs and turn into bricks down there, I guess. All right. So contrast has various actions that are important for the imaging technologist to comprehend, and diagnostic effects rely on adequate contrast considerations at the site. So each hospital and each outpatient clinic has their own protocol. You need to follow that protocol. You go outside of that protocol, you're outside your practice standards for that particular site. Don't do anything you're not comfortable with. Make sure that the patient is educated, they sign their consent, and agree to the contrast, okay? And make sure you're scanning the proper patient, proper exam. That's all for now.